Welcome everyone. This is our third patient education seminar for the Women's Health and Wellness Institute. So we are talking about bone density and do I need to worry about it, which yes, we all do, every one of you that's on here. And I'm super glad you're here. We have three amazing physicians here tonight. I kind of want to just go over very briefly. So the Women's Health and Wellness Institute works in conjunction with all of our other institutes at St. John's. You know, we have groups of physicians from across the spectrum, whether it's cancer or orthopedics, trying to figure out how to best take care of our patients, how to best educate our patients, what support our physicians need. So we have patient navigators, and I just want to briefly go over this so that you guys hear this. And your physicians have access to those navigators now. In a couple of months, we'll have our grand opening. But our three opening patient pathways are fourth trimester, and that is Marissa is our patient navigator. Pelvic health, which encompasses all of recurrent UTIs, incontinence. You guys were probably here for one of our other patient education seminars. And that's Courtney, and then Christina is here now for our survivorship, which is after any cancer. We work in conjunction with the Cancer Institute. There are needs of patients long after, like osteopenia, and so that is Christina there. So your physicians can get in touch with us, but please feel free to reach out. You know, our goal is to improve our programs and to educate patients. So any topics that you guys want to hear about, please let us know. We are so privileged to have so many amazing physicians taking care of all patients, but we're concerned with women's health. These are the upcoming patient education seminars. We will get this out on the social media for the Women's Health and Wellness Institute, but should I try alternative treatments to depression? What's the new hormone treatment? As many of you know, there's been a big change in whether or not hormones are recommended. Sexual wellness, pain to pleasure. Do I need to live with incontinence? Can I prevent dementia? And how do I choose a therapist? And then we have another one coming up, which will be, what do I need to ask my primary care doctor? So super excited to do these. We'll get these schedules out and published so that you guys can plan on them. These were just quick slides on the three patient pathways that we have open now. The next ones to come up will be hormone health, and then chronic pain management, because I think these are all things that affect patients. These are the navigators. Again, please reach out if you want these contacts. So I'm going to introduce Dr. Parvin Peddi, who is an amazing medical oncologist. She is the director of our Breast Medical Oncology at the Margie Petersen Breast Center. She just has extensive expertise in this area, and when my patients are struggling with hormones or osteopenia or anything like that, Dr. Peddi is amazing at helping us. She was at the Revlon UCLA Breast Center for over a decade, and we stole her. She also went to Duke, and I went to Chapel Hill, but I don't hold that against her. So she has really dedicated her career to advancing breast cancer care and research, and so she's going to join us tonight. The format for tonight, you guys, is that Dr. Peddi, Dr. Trentacosta, and then Diana Garrett, who also has a doctorate in physical therapy, are going to give you like a brief overview, and then we're going to open it up to questions. So please put questions in the chat. I'll field those and feed them to the speakers as it's appropriate, but we're just going to let them give their brief overview. So Dr. Peddi, welcome, and thank you so much for being here.
No, thank you for having me, Dr. Grunwald. And wow, what an amazing turnout. Like, we have 60 plus people who have joined. So I'm going to be speaking about bone density in the context of me being a medical oncologist, a breast cancer doctor. So I will I will not go too much into bone density and DEXA and stuff. Yeah, like there are specifics. Other panelists will go through that, but I will touch base on that and also kind of look at it from what it means for women in terms of breast cancer risk, as well as women who actually have breast cancer. What does that mean for them, whether they're under treatment or they're not? How does that have an interplay in terms of bone density test? So first of all, it's a big deal. Bone density is a big deal. So the title of the talk, when it says, do I need to worry about my bone density? Absolutely, yes. Hip fractures are a major cause of decline in our quality of life as we get older. Yes, heart attack can kill you, but hip fracture can really debilitate you. So if you want to be around in good health, this is a big, big deal. And as women, it's a bigger deal to us because it occurs 3 times more often in women compared to men. So it's even more important in women to really care about their bone density and not let that slide. And for every decrease in the bone mineral density, when you do a DEXA scan, a bone density test, and typically we measure it at the femoral neck, which is kind of like the top of the thigh bone. For every decrease in that, you have a higher risk of hip fracture. I mean, obviously, hip fracture is never zero risk, but you have higher and higher risks the lower the bone density is. And when we go through menopause, when we have less hormones, estrogen levels in our body, you have accelerated bone loss. So it goes hand in hand, and probably why it's more common in women to have this. But unfortunately, it's underdiagnosed and undertreated, which is why we are trying as one of the seminars to have this as one of the front and center talks, because most women don't think about it and they don't know, and they've never even been tested if they have osteoporosis. And if you look at the percentage, and this one just goes over Caucasian women because we have a lot of data on them, but it's probably similar in other races, but it's not as well documented, is that, you see 14% of women between age 50-59, and then goes higher and higher. 22% of women in their 60s have osteoporosis. About 40% of women in their 70s have osteoporosis, and a lot of women, 70% and above, have osteoporosis. And it doesn't have to be this way. We do have treatments. We do have things that we can do for osteoporosis. And a lot of times it's, number one, underdiagnosed. You don't even know about it. But even if you know about it, it's undertreated. A lot of women don't actually get the treatment that they need. So that's in general. Now, I'll let the other panelists talk about osteoporosis a little bit more in specifics. But why do I care about it as a breast medical oncologist? For a few reasons. One is, hormone replacement therapy can help with bone density. So as I said, when the estrogen levels go down after menopause, that is a major reason why bone loss happens. And if we give women hormones, that can help alleviate that. But it can help with increased breast cancer risk. And that the amount of it and degree of it, varies. Probably is not that much for women in their 50s. But let's say someone in their 80s is still on hormone replacement therapy, and I'm just giving extreme examples, that person's breast cancer risk significantly goes up with hormone replacement therapy. So one would preferably not try to prevent osteoporosis and trade that for increased breast cancer risk, from my standpoint. And then on the other hand, also, like that's for people who don't even have breast cancer in terms of their increased risk. What if someone already has breast cancer? If their breast cancer is hormone dependent, and the majority of them are, about 70% or so, if those patients especially get on hormone replacement, that can feed the cancer. So we really prefer not to have that happen. And on top of it, a lot of these patients actually need to be on anti-hormone medications to really cure the cancer. And that is not good for bone density. So a common class of drugs, they're called aromatase inhibitors that are used in postmenopausal women. They're great for breast cancer. They fight the breast cancer, but unfortunately, they can worsen the bone density. And there's another class of drugs for breast cancer. It's called tamoxifen that can help build bone, but it can now increase the risk of uterine cancer. So what does one do? So what do I do as a breast cancer doctor when I have patients who need to be on medications? So basically, the first step is diagnosis. So first step for patients who have breast cancer or not is to just ask for a bone density test and just at least know where you're starting out from. And then there are actually medications for it. So what do we do? So we don't trade treatment of breast cancer for osteoporosis, but what we do is that if we do have to do an aromatase inhibitor, that there are drugs that can cause osteoporosis or make bones thinner, we use medications. So Fosamax is a pill. It's taken once a week that can help with bone density, basically bones filling back up and becoming stronger. An injection called Prolia, which is every 6 months, is another medicine. An infusion called Reclast is another medicine. And all of these medicines, they can have pros and cons, and that is to be discussed with your doctor in terms of which medicine is right for you. But the bottom line is there are answers, and there are medications that can actually help, and there are many more outside of these. And as a breast cancer doctor, I sometimes, change my drug based on the degree of osteoporosis. So everybody that I see, I make sure that they have a bone density test. That's one of the tests that I order all the time. It's not just mammograms. And if someone has significant osteoporosis, in addition to starting them on some medicine for the osteoporosis, if it's really bad, then maybe I'll do tamoxifen for a few years and then put them back on the aromatase inhibitors. So there are things that can be done, but the bottom line is you need to know. You need to know what your bone's status is, number one, and to also be armed with the knowledge that there are lots of drugs for it, and it can actually be treated. So I'm actually going to, stop at this point, and since we're doing questions at the end, I will stop and allow everybody else to jump in so that I'm going to leave questions till the end.
Okay, I'm coming back on. Pushing buttons. There I am. Thank you so much, Dr. Peddi. That was great. I did already get a couple of questions, but I think what we'll do is we'll have Dr. Trentacosta give hers and Diana Garrett give a little spiel, and then we'll do all the questions and see which of you wants to answer, because there's you covered a lot of great information. Look, this is all about bone health, but we're coming at it now from a little bit different standpoint with Dr. Trentacosta. She is a pediatric and adult sports medicine orthopedic surgeon, specializes in prevention and treatment of sports-related injuries. So, this is treating women as they age, well, everyone as they age, but women. So with a lot of expertise in both non-operative treatment and surgical interventions. So she's worked with the LA Galaxy, the U.S. national soccer teams, and her passion is for keeping patients active and safe. And that's really what we want to do, especially as our bones age. So I'm going to turn this over to Dr. Trentacosta.
So thank you for that. So I'm talking about osteoporosis and how it now relates to the orthopedic surgeon. So osteoporosis, it's a medical condition in which bones become brittle and fragile, and it's often from this loss of tissue, which you can sort of see in that image on the left normal bone. You see how more dense that scaffold is of the bone on the inner part of the bone compared to osteoporosis. And so there is a thinning out of that scaffold that holds the bone together, and that's what makes the bones weaker. And this is often a result of hormonal changes, like we talk about in postmenopausal women and the drop in estrogen, but it can also be secondary to other issues like deficiencies of calcium or vitamin D. Often this is picked up and treated by primary care physicians in the past. So when we look at osteoporosis, it is a significant issue here in the United States, as Dr. Peddi brought up. And osteoporosis, we see in 30% of postmenopausal women in the United States, and even more, a larger percentage, 54%, are characterized as osteopenia, which is basically, which we'll talk about a DEXA scan, really between normal bone and osteoporotic bone. And 80% of people, of people who have osteoporosis are women. We talked about how it's much more prevalent in females compared to males. So this is very much, an appropriate topic for here. And worldwide, if we look at this issue, you're talking about 200 plus women who have osteoporosis. So what are some risk factors? We already talked about gender, female, particularly postmenopausal, secondary to the drop in estrogen. But there are modifiable risk factors depending on our lifestyle. Those are things like smoking, alcohol, poor nutrition. There are other things that are not modifiable. Those are things like family history of osteoporosis. There is, a genetic link that maybe, if you have mother, grandmother, aunts, uncles that have a history, you are more likely to have osteoporosis develop in yourself. Rheumatoid arthritis, long-term steroid use is another serious issue in terms of the development of osteoporosis. So how do we diagnose osteoporosis? Most of the time we're doing that with the DEXA scan. And this is a radiation-based study, but a very low radiation that basically is measuring the density most often at the bilateral hips, so both hips and your lower lumbar spine. And what it spits out essentially is a T-score. T-score is the one that we look at in terms of diagnosis of normal osteopenia or osteoporosis. And it's comparing your density to that of a young adult of the same gender who is essentially at their peak bone mass. So normal is going to be from 0 to -1. Osteopenia is defined as -1 to -2.5, so we're going lower on that scale. And anything less than -2.5 is considered osteoporosis. And we can use that information along with some of the historical patient data to essentially calculate a fracture risk. And this is easily found on the internet. I sort of pulled up this one quickly. But then that gives us and spits out a fracture risk score that then helps patients in terms of determining their fracture risk over the next 10 years. So who should get a DEXA scan? The general rule is women over the age of 65 and men over the age of 70 should have a DEXA scan in order to assess their osteoporosis. Anyone over 50 who has had a fracture, in particular what we call a fragility fracture, which we'll talk about in a little bit. Anybody with this family history of osteoporosis as they get older. People who have lost 1.5 inches of height are more likely to have an issue going on with their bones, because then we're concerned about loss of height coming from that spine or vertebral fractures. And those with any of those risk factors that we mentioned, alcohol abuse or chronic steroid use can increase the risk of osteoporosis in any individual. So On the Bone is a program that started in orthopedics about 15 years ago now. And it started because of this disconnect that has often been seen between primary care physicians and orthopedic surgeons, where primary care physicians were the main people diagnosing and treating osteoporosis in their patients, and orthopedic surgeons were just sort of treating the problem afterwards, what sort of came about as of osteoporosis. But orthopedic surgeons often see the objective evidence of a person's osteoporosis because of these fragility fractures, and we basically are managing the consequences of osteoporosis. So fragility fracture is any fracture that occurs from minimal or basically no trauma, fall from standing. You shouldn't be breaking your hip from just a simple trip and fall like that, or bumping into an object. Any of those fractures, the most common ones we see are in the hip, in the spine, or in the wrist. So why do we care as orthopedic surgeons? And it's about the consequences of the osteoporosis and low bone mineral density. We're seeing a significant amount of fragility fractures, hip fractures, vertebral compression fractures, and wrist fractures. And there's also another flip side. It might not be that we see a fracture, but the surgeries that we do, if we do it in poor bone stock, will have poor fixation of implants. So it makes our surgeries that we do, whether it's sports medicine or orthopedic trauma, less successful. So the outcomes are poorer in patients who have osteoporosis. There's also an increased fracture risk in our patients, as well as these increased failure risks. So hip fractures, like we talked about, these are the most devastating consequence of osteoporosis, and Dr. Peddi touched on this as well. We see over 10 million hip fractures per year in people over 55 globally. And we know these lead to chronic pain, reduced mobility, disability in patients, and this increasing degree of dependence that wasn't seen before prior to the fracture. Up to 25% may need long-term nursing care. What I always tell patients when I see them, even though we did talk about a lot of sports medicine, I do take emergency call at St. John's, so I see a lot of hip fractures. And I always counsel a patient that they may fall or drop down a level of mobility prior to what they were before the fracture. And we see this a lot in the literature. There's also a significant mortality rate, 25% in that first year following a hip fracture. And 50% of these hip fracture patients have had a previous fragility fracture, meaning vertebral compression fractures and wrist fractures being the most common. So they've had that diagnosis, sort of like a little red flag that's come up in their history. And close to 80% of hip fractures that we see never have received any medication to treat osteoporosis. Vertebral fractures, compression fractures, are actually the most common consequence we see of osteoporosis, but they are also very severely underdiagnosed and undertreated. They lead to back pain, loss of height, deformity. Commonly what you see is that hunched over appearance as patients get older. And that's because of that wedging fracture that you can see in the picture on the right. In the red, what it's pointing to is a compression fracture. And you can see how that then will throw that upper body above that forward and giving you that hunched appearance. And this can, if happens at multiple levels, can lead to reduced pulmonary function. There's also an increase in mortality rate that we see in patients with vertebral compression fractures. And as we talked about with the hip fractures, it also conveys an increased risk in other fractures over the next year or two. It's often undiagnosed and overlooked, just chalked up to back pain. Over 50% of patients with hip fractures have evidence of these prior vertebral fractures. So what is osteoporosis treatment? First is, who do we treat? It should be offered to patients who have that T-score of negative 2.5 and below, so patients who have osteoporosis on DEXA scan. Anyone who has had a hip or vertebral fragility fracture is also considered having osteoporosis. Osteopenia. Osteopenia. Patients who have osteopenia and a 10-year probability of a hip fracture greater than 3% or major osteoporotic fracture greater than 20% should also be considered for osteoporosis treatment. So this is based on that fracture risk assessment score that we were talking about on the previous slide. And what are the treatments? Dr. Peddi touched on the medications that we have. There's two main classes: anti-resorptive medications, which are basically trying to prevent the breakdown, and then there's anabolic. They're trying to build up the bone. Calcium and vitamin D supplementation often complements medications like that. We try to decrease those modifiable factors, risk factors, like alcohol use, caffeine use, tobacco consumption. We try to instill fall prevention techniques and work on strengthening to help and improve balance, and just increasing physical activity, in particular weight-bearing activities. And this is not just a primary care physician problem. It's not an orthopedic surgery problem. It is really a multidisciplinary team approach that should be seen with osteoporosis. These are just some, but obviously there are so many different facets that should be included and need to be included to improve your health. So it is this often silent, we refer to it as a silent disease that affecting a growing number of women here in the United States and globally. And the consequences of osteoporosis can cause significant morbidity and mortality in our patients. So the treatment of osteoporosis, like I was mentioning before, really has shown to help decrease the rate of fractures as well as decrease morbidity, mortality in patients who have osteoporosis. So I think we'll go next.
So, Dr. Trentacosta, I'm going to have you sit there. Diana, I'm going to have you come up and sit here. We have a ton of questions, and both Dr. Peddi and Dr. Trentacosta work very closely with physical therapy for the non-surgical approach to treating osteopenia. But there's just a bunch of questions, and I feel like all three of you can answer these. But I do want to give Diana Garrett an introduction. She has, as I said, a doctorate in physical therapy. She is board certified in orthopedic clinical specialist. and has advanced training in oncology rehabilitation. So in both of these areas and lymphedema management, she is a treasure, and most of my patients see her. So I really appreciate her her expertise. So Dr. Peddi, can you turn your camera back on? Not quite sure how we're going to make this work when we post this, but then at least we can see you. So I'm going to go through these questions. There'll probably be more that are coming in, and just see what your answers are to this. So thank you so much. So what does insurance cover? What do you guys talk to your patients about? Do most of them get their bone density scans from their primary care doctor? Or, as Dr. Trentacosta said, a lot of times they've never had one and they come in with a bone fracture. So what's the advice for patients in this area?
In terms of what insurance covers, I'm never the best person to answer that. But I definitely have issues with some of those newer medications.
Okay.
I have had issues with insurance coverage for that.
But not with the DEXA scan?
DEXA scan.
Or you don't really order that?
I do sometimes. If they haven't talked to their primary care doctor and I want them to get started, like get the ball rolling. Because truthfully, yes, it's nice to have a team leader when it comes to the osteoporosis treatment plan.
Yeah.
A primary care physician knowing sort of all the medical problems and all the different facets of medications they're taking is sort of best, because there is a laundry list of medications that can be taken.
Yeah, and that's another question which we'll get to. But Dr. Peddi, I mean, I'm assuming most of your patients have a cancer diagnosis, so that may make it different than someone who's 55 and goes to their primary care doctor and says, "Can I get a bone density scan?"
Yeah, so my patients, all have breast cancer, but I think the current thing is like every 3 years Medicare covers it, and most insurance companies are the same.
We'll cover that.
Yeah, we'll cover a DEXA scan every 3 years or so. So sometimes I would get pushback if I'm trying to schedule it more frequently than every 3 years. So sometimes we can wing it because they're on cancer medications, but sometimes not. So the normal is postmenopausal every 3 years.
So postmenopausal, some people's menopause lasts a period of time. So how do you think about that?
I don't know. I think like in their 50s, most people won't have, significant osteoporosis unless it's genetic.
So not when you're completely done, but just when you're kind of in menopause. Is that Dr. Trentacosta?
Right. When you're done with your, menses and stuff.
Okay.
But I don't know when Medicare really starts. I have to look that up, like it starts paying, but it may be more than 60.
And in general, just so that you guys know, if Medicare covers something, the other insurance companies should cover it. So they set the tone. So while we're on this, so what I gathered, and somebody asked a couple of questions, but these are a couple put together. So you start with Fosamax, then you go to Prolia, then Evenity, and then back to Prolia. What's the?
Not necessarily, like it really depends. Like Fosamax can cause upset stomach, and it has a specific schedule of like how to take it and stuff. So not everybody can do it. You have to be fasting a certain amount of time before, upright a certain amount of time, not with certain medications. So if patients really want pills, then that's good. But in a lot of times, I actually prefer not to do Fosamax because of all these issues with it, and would rather give them once a year reclassed, which is the same class of medications. And you get it in the office. It's a little IV infusion. It lasts 30 minutes. And then you're good for the whole year. And as long as there are no dental issues. And I know somebody.
That was another question. Yeah.
Exactly. So, and that's something I didn't touch base on. And it's a rare side effect of any of the osteoporosis medications, whether it's injection, whether it's a pill, it's an IV, doesn't matter. Like any of them can cause this thing called osteonecrosis of the jaw. Basically, the jawbone can get hollowed out. is a pretty serious thing when it happens. But it almost never happens if someone doesn't have dental issues or major dental work. So whenever I'm starting someone on anything for osteoporosis, I have them check in with their dentist, make sure their teeth are good, there's no major dental work being planned. And if that's the case, we're almost always okay. But if that's the case, then I personally prefer the IV that is once a year. But Prolia is also good once every 6 months, is an injection.
Do you time out of either of those, or can you continuously take it?
Continue. And Prolia is really supposed to be kind of like ongoing and indefinite kind of thing. You can get a rebound if you stop Prolia, actually.
And Dr.
So
Trentacosta,
your question, I think, is like alluding to, the fractures that we've seen. Traditionally with bisphosphonate medications, we had seen, and this, I remember this in residency, I will say, I have one patient that I had in the past year, and I hadn't seen in such a long time, that there is a specific fragility fracture that develops because of the medication overbuilding brittle bone in this area in the femoral shaft, particularly right under the hip. So there was the recommendation for bisphosphonates to go on holiday after, usually it was like after 5 years. But now there's so many medications available, and they've, we have not seen that.
So it sounds like both of you kind of switch it up. You have somebody on something for a period of time, and then you switch to another one, and then you're checking with dental X-rays, with X-rays.
I leave it to the dentist. I generally leave the dental stuff to the dentist. I don't do any dental X-rays.
No, but I mean that you send them to the dentist for X-rays.
Absolutely.
No one else wants to do those. Stick it in the mouth, no.
So no, but so if I start someone on Prolia, I usually just continue. If at some point they're like, I'm tired of this and the bone density is fine, then you do usually need a bridge, like a reclass for a year or two to get off Prolia, because it can be a rebound worsening of the bones. Even if they're good on Prolia, when you stop it, they can get worse. So you need a bridge of reclass to get them off. Reclass itself doesn't need a bridge, but it has the problem, like Natasha mentioned, that it can make the bones brittle if you use it too long. So that one usually is about 5 years or so, and then you try to back off and not do it.
And do either of you manage this, or you manage it with their primary care doctor?
If they're on active breast cancer treatment, I manage it. Once they're done with active breast cancer patient, then they don't need to see me as often.
Then they go
see their primary care doctor. But I try not to give them too many appointments when they're already seeing me. So I manage it when they're seeing me.
So there's another question, and Diana can help us with this, because this also has to do with the non-surgical, treatment. And if you are diagnosed with osteopenia, and I know a lot of times the diagnosis comes as a percentage, right? So can you return to normal? Who wants to start? Diana?
I feel like that's a loaded question.
It's loaded, but it's also like, what do you do when somebody comes to you and is like, I was just diagnosed with osteopenia and my doctor told me I need to do bone strengthening?
Yeah, so weight-bearing exercises, resistance training can help mitigate some of the bone loss. Our peak bone mass is in our 30s, and then we gradually lose it, which is very depressing to think about, that it can only get worse. But what happens when you integrate like exercise and resistance training into your regimen, you can slow down that bone loss. So essentially you become into the norm of bone loss versus underneath the curve.
Okay. And when you're talking about strengthening exercises, is that weights, hiking, running? What are those? Give me top 5.
D, all of the above. So anything that'll get you moving. I hate to call it exercise. I want to call it physical activity because it's going to be different for every person. I look for more kind of moderate intensity loading exercise. So that's going to be walking, stair climbing, pickleball, dancing, trying, depending on the person, if they're not used to physical activity, it might be kind of lower impact and building up to that versus like doing box jumps and squats and lunges and running, which can impact your joints to 3 times your body weight. So we want to kind of load progressively through it.
Okay. Dr. Peddi, Dr. Trentacosta?
One thing that I find it easier to tell patients is like, there's so many things that count. as weight-bearing exercises, like Diana said. I tell them what doesn't count. So the things that don't count is unfortunately swimming, as well as biking. So I'm like, those don't really count, but do everything else, almost everything else.
What about Pilates? Somebody just asked about Pilates. Doesn't
It's
count.
good.
It does?
It's lower, but it's still good for, it builds muscle.
Okay.
And depending on how intense you do it. But yeah, the cycling and the swimming, as much as I love it for joint health, is not great for osteoporosis treatment. But walking, oftentimes I would say it's like, it's a medium impact, and a lot of patients love doing that. That's super helpful.
So you're not going to, are you going to improve your numbers, or you're just going to keep them from decreasing?
Both, essentially. Is what she was trying to, Diane. No, because it's because you're 8. I mean, I've seen numbers improve on patients on their DEXA scan, but it's that you're sort of slowing that you're improving that comparison, as you get older. So you're improving yourself on the curve, even though technically, like, the hard number of like.
So we're always going to lose bone mass.
Yeah. Okay.
And you're trying to stay on that normal curve of bone loss. And when you become osteopenic or osteoporotic, you're below that natural curve. And so the exercises and the medications help you return back to that normal curve. You're going to continue to lose bone density because that's just the nature of the course, but you're going to lose it at a more normal rate.
So that's why it's technically both.
You're just not going to grow more bone, which I think is what people always think, that like, oh, my bones are going to grow more. You're just going to mitigate the loss of it. So it'll make the bone more dense for your age.
So, Dr. Trentacosta, you showed an internet survey, correct? Can anybody take that, and should they?
You could theoretically, because it will show, if you know your DEXA scan number, which you can get from your online portal, and you'll know your history there in terms of family history, any sort of drinking, tobacco use. Is a good idea to know, because it gives you a spit out of, in 10 years what your hip fracture risk, which is our biggest concern, because that's the one that's most associated with morbidity and mortality when we talk about this fragility fracture. So that's why you saw that threshold was much lower. We're talking about like 3%. If your risk is 3% or higher, we get worried, okay? In the next 10 years versus, other fractures. Wrist fracture is a common one we see in postmenopausal women, just simply tripping and falling, catching themselves, and they break their wrist. That we have a little bit of a higher threshold because it's easier to treat. There's less, morbidity associated with it. It's still a pain in the butt, for the patient to treat. But it will then give you a sense of your fracture risk, and that's what is used to help, decide on osteoporosis treatment. It is a hard discussion.
But you have to have your DEXA scan.
You have to have your DEXA scan. You
that.
can't do it with, you can't do it without a DEXA scan. Yeah.
And so DEXA scan is when you're in menopause, postmenopausal, but if your menopause is like 7 years, you just kind of do it. And then Parvin, is this for any patient who undergoes chemotherapy, not just breast cancer patients? Is that the risk factor, is the chemotherapy?
I think if the chemotherapy puts them in menopause, it's the effect on the hormones. If someone was premenopausal, got chemo for some cancer, and that chemo put them in menopause or accelerated them going through menopause, then that's the major impact on bones. It's not the chemo drugs themselves, is whether they put that person in menopause.
Okay.
Breast cancer has the additional thing of then you're going to be on anti-hormonal in addition to whatever chemo did. So that's the additional thing with breast cancer. But any chemo can hasten someone going through menopause and basically accelerate bone loss.
So Dr. Peddi, you may not have an answer for this, but I think Dr. Trentacosta and Diana will. So if somebody has a diagnosis of osteopenia, do they need to see an orthopedic surgeon? Do they need to see a physical therapist? Like, what do you do when you get that diagnosis? Do you just do it on your own, or do you get help? Do you get advice?
That's a good question. I do think it's a good idea to, at the very least, talk to whoever ordered you that DEXA scan, usually the primary care doctor. But the idea is you're at risk. And then the question is, what are your other risk factors? And that's where that, risk fractures, the FRAX score comes in.
Okay.
Incorporating your other risk factors, because you may be osteopenic, but if you have a significant family history, if you, had a significant tobacco history in your past, that may put you at a, significant risk of fracture.
Right.
There's, we look at these numbers where not every hip fracture has a definition of osteoporosis based on their DEXA scan. Okay, there are osteopenic patients. There are normal patients who develop break their hip from a standing. Okay,
Right.
not from falling. From
A
2
tree.
stories. Yeah, from a tree. So what kind of put them, even though they're not osteoporosis, is there's other things that play into it. It's multifactorial. So I think it's an important thing to talk about with primary care doctor, because medication may be an issue, maybe a discussion,
option.
an option, discussion point, and calcium, vitamin D supplementation. So physical therapy, and
How many patients do you see in physical therapy who just got their diagnosis of osteopenia and their doctor recommended them for physical therapy?
Not as many as I'd like to.
Yeah.
I'm not going to say that physical therapy is the end-all be-all and will help everything, but physical therapists are movement specialists, so we really look at how people are moving and are able to guide you in exercise to whatever dysfunctions that you're having. Whether you're working with a personal trainer and that works for you, a physical therapist can tailor everything to you. So I love to see people coming in being proactive about it, because it's not just, okay, what exercises can I do, but it's also fall prevention and balance training to make sure that you don't increase your risk of developing a fracture from a fall.
And it's not just bones, it's also muscles, because these patients are also often have sarcopenia, wasting of the muscles as well. So that,
That then leads to poor control, so they fall and break a bone. Interesting. Okay. So that was the internet test. Let me see what else I've missed. How much weight-bearing exercises do you have to do each week to prevent osteoporosis?
That's me, isn't
I was going to
that?
say a lot.
So the American College of Sports Medicine put out exercise guidelines of you want 150 minutes of moderate activity per week, or 75 minutes of vigorous activity per week. And that's going to be different for each person.
Okay.
Right? Like my moderate activity is I'm breathing heavy going up down the stairs. So I'm not going to lie. That is moderate activity for me. And it doesn't have to be all at once. People say get 30 minutes of physical activity. It doesn't have to be just 30 minutes all at once. It can be broken up into 10, 10, and 10. And so integrating resistance training, getting your muscles to strengthen and work and pull on those bones to strengthen them, doing the balance training to incorporate into those exercises. Your goal is the 150 minutes per week.
Okay.
it sounds intimidating, but if you
But you can do it. You can break
do
it up.
And find activities that you like doing. I know you mentioned pickleball, but pickleball brings a lot of interest
I know.
into my
I know.
office.
I was I'm treading on a very thin line right now saying pickleball, but it is something that gets people active.
It is.
And I think that's the thing. You have to figure out what works best for you. My mother loves gardening, and she's I am breathing heavy when I'm in the garden. I'm pulling out those weeds and stuff. I'm great. But now you got to go for a walk too. You got to get the impact. The gardening is great because you're using the muscles to pull and dig and all that stuff. But now we need a little bit of some impact also.
Okay. So I know there's a bunch of you on Zoom. We have some people here. So there's a question.
I heard somebody say that caffeine and wine are not necessarily good for osteopenia or osteopenia. Can you talk more about that?
So the question is caffeine and wine, is that good or bad?
How bad and how much is that?
Moderation is good. Excessive use. When we're talking about alcohol, wine, or caffeine, we're talking about excessive, more than 3 drinks per day. Okay.
3 cups of
Wine.
coffee.
Oh, coffee. Oh, you're talking coffee. Oh, I was going back to 3 drinks of coffee is also a lot in a day. I would probably stick with 1. Yes. So the more you tread into, out of the moderate zone, the more likely you're going to increase your risk.
And Dr. Peddi, do you have different recommendations for your cancer patients with caffeine and wine?
So, yeah.
I figured.
So, the thing with wine is that, irrespective of osteoporosis, alcohol increases estrogen production. So, alcohol independently increases risk of breast cancer, hormone-dependent breast cancer. And probably the benefits of it have been a little bit stretched, probably is not as beneficial as we would like to think. So I tell people it doesn't mean drink, but maybe don't do it a regular thing, just
Moderation.
with moderation, exactly.
Maybe more moderation. We have the Italian here. Like that's the.
We have to figure out not to the French, not to the Italian people. But as far as caffeine, a cup of coffee, 2 cups of coffee is fine. And it probably does have cardiac health benefits and otherwise. Is it great for your bones? No. But a cup or 2, it's okay.
Okay.
So again, moderation.
Yeah. Okay, so there's a couple of questions here so this one is about, I have osteopenia, I'm very active but can't take calcium. Does that mean that they can't also take the Fosamax or the Prolia or the Reclast? Or they just,
They can take those. And
Okay.
They recommend they can do those things.
okay. And then there's another one that talks about, okay, this is way above my pay grade, but if
I
one,
doubt that.
if one has osteopenia, can one go straight to anabolic medication, I don't know which of those are, to increase bone density and not take the anti-resorptive meds? There's concern that the anti-resorptive, maybe you guys can tell us what the difference between those two are, will interfere with acid reflux GI issues.
Well, Natasha had those categories on her slides, so I'll let her weigh in if she wants to.
So yeah, in terms of which medication that I've sort of seen in practice, it doesn't matter which one. It's a discussion in terms of side effects of
all of them,
all
right?
of them, yeah. That's why there is no. I know you mentioned this to that to this. There's no written report of this is the best way to follow because every person is different. Osteopenia, particularly if you have other. Going back to the stem of the question, osteopenia with a high risk of fracture in the next 10 years based on that risk assessment,
Yes.
You do start considering adding medication. So then the question is which medication, and that yes, there's some that have more GI upset and reflux. I don't know all of the particulars on them, but you don't have to start with.
So you showed a whole list of who the team is that should be involved in this.
Yes.
By the way, I did not see ChatGPT on there.
Yeah,
But who's
people love that one.
who's the one who knows the most about the pros and cons of all of these medications because there's so many,
Yeah,
right?
there are some primary care physicians that are very, I will say, well versed in it, and particularly geriatricians
Okay.
and endocrinologists are probably the two that manage it the most. In that, in the sense of knowing all the details, and then on top of that, really being on top of the other health problems in the patient as well as the other medications that patients are on to make sure that there's no significant interaction.
Okay.
Yeah.
So there's a question here. I'm not going to get into the specifics of it, but I think that the gist of it is important. A patient with osteopenia, her doctor's recommending a medication. She wants to try heavy lifting first. Is that reasonable? And Diana's you can start.
I don't want anyone to think that they have to lift heavy to have benefits. You just have to lift something.
Which can be your own body weight.
Which can be your own body weight to start with, and then gradually increase from there. There's the 4 big movements that we really look for is a hinge, a squat, a pull, and a push.
Are you going to demonstrate?
No. So even just doing a squat is moving from sitting to standing. If you go from sitting, you stand up and you sit back down, you've just done 2 squats.
Okay.
So you can add holding a book to it, and now you've added some resistance to it. So now you're working the muscles a little bit harder.
Amazing.
And it's things that you can integrate. Like if you see me around Santa Monica, you'll probably see me with a weighted vest on. And it's
Okay.
just adding a couple extra
Rucking.
pounds I don't know, go that far. It's just adding a few extra pounds to give a little bit more force through my bones. Because every time I take a step, I put a force into that ground, and then an opposite equal force goes back up my legs, and that stimulates the bones. And so it's just things like that where you can add a few pounds here and there, carrying groceries, that counts.
Yeah.
You know, picking up a grandchild, that counts. Some
Okay.
of those grandchildren can be heavier than what you would pick up in the gym. And I think, you know, the women that I get to work with in terms of doing exercise guidance, they're surprised that they're stronger than they think. And it's just a matter of fine-tuning what exercises work for you with what equipment you have, but you don't necessarily have to lift heavy to get benefits.
That's great information. Dr. Peddi, I'm going to come to you, but Dr. Trentacosta, when patients say, do I have to take the medications? Can I just do weight bearing?
A lot of my patients do not like taking medication, I think.
Yeah.
I think it's a common, I'm sure you hear it too, in your field, is that, you know, they hear this side effect, that side effect, and it just turns them completely
Correct.
off. And I mean, I tried to show the data of, I mean, we're literally talking about these medications can help decrease fracture risk, decrease mortality risk
Right.
in patients that
And
have
keep you
osteoporosis.
active.
And yes, and keep you active. I mean, I try to, you know, push that idea. But I understand, you know, if you have a side effect, you have a complication, even though I may tell you it is like 5%, you know,
Right.
whatever
It's
small
still-
number.
it is.
If it happens to you, it feels like 100%.
Yeah.
So it is not inappropriate. It's your body, you own your body, and your decision making is on your body. So I do appreciate that if they don't want to take the medication, they really look at the other stuff too, the calcium, the vitamin D, you know, making sure that those modifiable risk factors are minimized as much as possible. The weight bearing, which you gave many great, you know, examples.
Great examples, yeah.
So that you could do on your own. You can join classes at the YMCA, you know, it doesn't have to be go to Barry's, you know,
Right.
you don't have to run on the treadmill. You don't have to do that, you know, but, you know, you could do simple things at home. You could get your rucksack and
So
and
we're
your
getting
ankle
close.
weights.
Dr. Peddi, I'm going to add one more thing. If a patient tells you, I don't want to take the medication yet, can I do weight-bearing exercises? How long would you give them? And then would you say yes and just take another DEXA scan in 6 months or in 3 months?
Try to work with people. That's what I try to do. So depends. You know, if it's horrible osteoporosis, I try to be straight with them. Like, hey, I don't think we can overcome this. But if it's borderline, we say, okay, let's give it a shot. You do what you can, and we have to go at least a year before insurance will approve it again. So I'll give it a year and do the bone density again. And meanwhile, make sure that at least the calcium level is good, the vitamin D level is good. And maybe have a reminder again 6 months, you know, into it's like, hey, you know, your DEXA is coming up. So to see what they can do from their end, and then see if it's stabilized, that's great. But if not, then that's our cue.
Okay, so we have only 3 minutes left, but there's 2 more questions that I want to do. Well, actually, one is just a repeat of the 5 top weight-bearing exercises that are reasonable for most people. And Diana, I'm going to have you start with the 5, and then I'm going to see if Dr. Trentacosta and Dr. Peddi want to add one that works for their patients.
I put my answer in the chat box. So my answer is that.
Oh, good. All right, Diana.
I'm going to go with walking, stairs, dancing.
Pickleball?
I'm not going to go, she's going to kill me if I say pickleball.
Get Achilles ruptures
And
arthritis.
Hamstrings, no big deal. This is fine. Resistance training is
Okay.
up there for me. So those are my top 4.
Dr. Trentacosta, would you add anything into there that's been easier for your patients?
I mean, the biggest thing is finding something you like, and that gets you kind of moving, hopping around. And that, I think those are the top ones is walking with my patients.
Okay. And then there's been a couple more questions, which we did go over. It's a little interesting, like, can you not take the medication and just do the weight bearing and improve your osteopenia? So, Diana, I thought you gave a brilliant answer to that. Will you just do it one more time with the curves and the...
So our peak bone mass is in our 30s, and then we're on this curve of bone loss.
Not a downward spiral, but a curve.
Not a downward spiral, but like a gentle slope.
Okay.
Until menopause.
Until menopause, and then it's just, I don't know. And so When you are osteopenic or osteoporotic, you're below the curve.
Okay.
And the goal is to get back to the curve, back to that normal estimated bone loss that we're anticipating to see. So exercises, weight-bearing exercises can help mitigate that curve, that bone loss, so you can get back to the normal levels. It's all about getting back to those normal levels of bone loss.
Okay.
And not necessarily being above the curve. I might
Okay.
be worried if you're above the curve.
No, I think that's good. And I'm so sorry we're at time. This was like such a great discussion. And really appreciate all of you being here, both in person and on the Zoom. And we will put out hopefully the next 6 so that you have them all, before the week or two before, so that you can see those, because I think we have some amazing discussions coming up. Dr. Peddi, Dr. Trentacosta, Diana Garrett. It was amazing. Thank you guys. Have a good night.
Bye.